came across an article in the Science News that suggested that there might be a link between abortion and breast cancer. And I looked back at the literature and realized that enough papers had come out to support that hypothesis, but no one else was talking about it. So I knew that that would be a project for me. And eventually, in doing that kind of research, it naturally moved on to the effects of birth control pills, of oral contraceptives, which are also steroids. The difference is that they're really synthetic drugs that act like hormones. They are called hormonal contraception. People say they're taking hormones, but they're not. That's one of the little lies that makes it seem okay, like you're taking a natural substance. No, these are all chemicals which are what are called xenobiotics. They are not made by living things except in laboratories and factories. And so they aren't hormones, they're drugs, they're synthetic drugs. And just in that paper that you mentioned, the systematic review and meta-analysis on Depo-Provera and the transmission of HIV, we pointed that out very clearly in the opening paragraph that we call them injectable or steroidal contraceptives. We did not call them hormonal contraceptives. That's very clear in my paper, in our paper. And well, hopefully that will catch on at some point. But that was just a natural progression of my working on abortion and getting to know a lot of other people, a lot of pro-life people, for example, who were doing research on abortion and contraception. And you could see that there was a lot of political opposition to finding anything wrong with these things. So it's been quite a journey. And I would say that probably half or more of my research effort in studying breast cancer, for example, and other consequences of steroidal contraception is really studying the papers that were published about them, because a lot of them are fraudulent. And so they became the object of my inquiry as much as the original subject itself. So it's been quite an interesting journey. Not exactly a quiet corner of science and medicine. Okay, well, as I said, all of these steroids are synthetic drugs, and Provera. I didn't say Depo yet, but Provera is one particular synthetic steroid that acts like progesterone. And it is those steroids that act like progesterone, which are really the basis of contraceptive steroids, because during the first half of the menstrual cycle, the follicular phase, there is no progesterone around. There is no progestin around. And if you add progesterone, or some other progestin, like Provera, it will do what progestins do. And one of the things it does is it inhibits ovulation. So this is largely how it works. It does other things because progesterone is supposed to be during the part of the cycle when conception is not supposed to happen. It does a lot of other things, to make it, to change the nature of the reproductive apparatus in a woman. So Provera then is one of the synthetic progestins. Now, the reason this is very important, because it's actually a phenomenon, a characteristic, which is even more so than just contraceptive steroids or any steroids or most drugs in general. And that is, when you make any sort of medication to be taken orally, the first place it goes when it's absorbed is to the liver. And the liver's job is to break it up. So if you took just progesterone, it wouldn't work as a contraceptive. If you took just the progesterone and estrogen combination, synthetic estrogen combination that they put in birth control pills, generally, neither one of them would get into the general circulation at effective concentrations, because the liver destroys it. That means they really have to be synthetic compounds which are resistant to biodegradation, right? Not really, they should be as non-biodegradable as possible, which is another dirty little secret, that the worst pollutant in the world now, the most dangerous to the water supply and to human health, is the estrogen part of what's in this in the cocktail that usually is used for contraception, and that would be 17-alpha ethinyl estradiol. So we're not talking about that one right now, but these, because they are taken orally, they need to be resistant to biodegradation, and because they are resistant to biodegradation, they are important pollutants because most of it is excreted without appreciable chemical change, so they're still active in the environment. But that's, as I say, another issue. As far as Provera is concerned, there are many synthetic progestins, but Provera is unique because it happens to perfectly mimic the hormone cortisol as well as the hormone progesterone. They are very similar. And other synthetic progestins will have other side effects that are related, for example, to their ability to act like androgens, a little like testosterone, so they may give superficial hair growth and some other side effects like that. But Provera, which is also, that's a brand name of what's called medroxyprogesterone. Medroxyprogesterone acetate is implantable, or it's injectable, because it's very, very, very insoluble in water. Not completely, but it's so much so that you can inject it at a site under the skin. Just inject basically an emulsion of this steroid under the skin, and very, very slowly it will leach into the circulatory system, providing a relatively constant amount of steroid, of progestin in this case, or specifically Provera. That is medroxyprogesterone acetate. Now, the fact that it mimics cortisol makes its side effects really serious. I mean, cortisol is the main hormone that's the stress steroid hormone. That when you undergo stress, that's when cortisol rises. Of course, the most stressful thing most people do every day is get up in the morning, and that's when your cortisol rises in the morning, which is why people say, and I'm one of them who says you don't really need to eat breakfast. They call it intermittent fasting. I just say your brain, an hour before you usually get up in the morning, your brain sends a hormone out that tells your pituitary gland to send another hormone out to tell the adrenal gland to send another hormone, cortisol, which tells your liver to make you breakfast. And it also gathers up the ingredients from the rest of the cells in the body. Now, you're not supposed to have high levels of that all day long, a constant infusion. The only kinds of people for whom that is appropriately indicated are those who have organ transplants, because they need a lot of cortisol, because cortisol in high doses is an immune suppressant. Well, if you're worried about a sexually transmitted disease, what do you think an immune suppressant is going to do? It's going to make it easier to transmit. So this is kind of, for those people who are schooled in, in reproductive steroid drugs like I am, this is kind of a no-brainer. I mean, it's going to suppress the immune system. It's all about a virus which suppresses the immune system and which you don't want to spread. So you find that in the U.S., a lot of the spread of HIV is through anal sex. And it's not, vaginal sex, ordinary, biologically natural sex is through the vagina. And the vagina naturally has a multi-layered characteristic. It's like external skin. So it's made for that sort of activity. But the lining of the rectum and the anus are not. That's just simple epithelium. And so it's easily torn, bleeds, fluids exchanged allow for the passage of these things. But the vagina is relatively resistant unless you're taking something like Depo-Provera. So it increases the transmission of HIV in women. And this was shown starting in the 1980s when they looked at it, where HIV among women became rampant, essentially among prostitutes. They call them sex workers now, I suppose. But among sex workers, among female prostitutes in Thailand, other places in Southeast Asia, but Thailand is where a lot of the early research was done. And then it was done in other places. Probably most of the research at this point has been done in Africa, where the international population controllers would just love to see more and more and more Depo-Provera because it's easy, it's convenient, it's cheap, and what they want to do is keep down the number of, we don't want too many black people in the world. They might start emigrating elsewhere, right? This kind of you know this sort of not so subtle racism, which is part of the whole worldwide population control movement. They really want everybody controlled, but especially those black African people are kind of problematic, right? So they're spreading, and no, understanding their mentality is like, if it causes more women to get sick and die, well, that's good. We want to keep the number of people in the world down, don't we? And so you have so many of these now AIDS orphans, women who get AIDS from the population dislocations of industrialization, keeping the husbands and wives apart for months at a time, and then the social consequences result in the spread of more venereal disease, more reproductive infections like HIV, and a lot of times these workers, they'll bring it home to their wives, and their wives are not resistant to it because the wives are being given this all these Family Health International and all these other allies of the UN Fund for Population and all of that would love just do whatever they can to distribute this stuff for free, and so it has it has that effect of cortisol. That I think is number one, and I'll get back to what that has to do with our petition and our paper, but. Another serious side effect of long-term synthetic corticosteroid use, like transplant patients appropriately get, is that it causes bone loss. Cortisol basically, mobilizes. What it does is it mobilizes protein from tissues in general, and when you mobilize or dissolve away protein in order to harvest it for use in a stressful situation, then the balance is upset and you get more loss of bone over time than the bone is replaced. So the bone is a very dynamic situation. Everybody thinks, oh, it's like a skeleton. You have a skeleton maybe of somebody in the laboratory who died 100 years ago, and it doesn't change because it's dead. And your skeleton and mine may look the same as they did 30 or 40 years ago, but they're not the same atoms and molecules in the collagen matrix of the bone. So you end up having the imbalance such that more bone is lost than reformed, and gradually you get a net loss of bone tissue. And so that's not a good thing, especially when you're in what they call a third world country, a developing country where where the manual labor really predominates. It's not women don't necessarily have a tough time at the laundromat. They may have a tough time at the river where they're hand scrubbing every garment. It's requires a lot more strength, carrying urns of water and so on. And you have people who are really dependent upon having good muscles and good bones to carry them around. So it's it can be bone losses can be devastating, as women even in the West would know. However, in the West, the difference is, so this now gets to the subject of our FDA petition, and this was echoing what we had said in the paper, that we really believe DMPA should be taken off the market in the U.S., because in the U.S., Planned Parenthood and everybody else, they have all the contraceptives you want, whatever brand, whatever kind, a ring, an injection, a pill, whatever you like. What would you like? As long as you get some kind of contraception, we'll give it to you. And they're all impregnated with these steroids of one kind or another. Or not, they may be mechanical mostly. The point is, this is the only one that has this side effect. DMPA alone, among all of these available, quote, safe contraceptives, safe enough for women to take them for many years and most of them not to die from it, right? That's what they call safe. But among all of them, it's only DMPA the Depo-Provera, which acts like cortisol and which has these side effects, therefore, of increasing HIV transmissibility and of causing bone loss. Now, of course, it also is a progestin. You also get things like psychological effects, depression, the panoply of side effects that we wrote about in our paper. But in that way, DMPA, Depo-Provera, is pretty much just like the rest of them. But it's pretty important if it's going to double, increase by 50 to 100% the transmissibility of HIV. I mean, that results in millions of cases. And you can make the argument, it's not a good argument, but you can make the argument that, well, in these developing countries, you're very far from the clinics and it's hard to get something that's injectable, and this one is really cheap and it's really available and it's really so on and so forth. Well, fine, but you can't make that argument in the developed world. There's so many options. And it's not as if they're on the shelf. Try this option and the NuvaRing and the all the other brands, and then you'll see here's Depo-Provera. Watch out that because it increases HIV transmissibility. No, they don't want to say that. This is where the politics comes in. You have to fight tooth and nail, as you noted in your very kind introduction. The WHO has acknowledged it. Oh, but finally, and so begrudgingly, and so buried that they still recommend Depo-Provera in places like Central Africa, Sub-Saharan Africa. And they'll tell the workers administering it, they'll say, well, this is something that maybe not all women can take it safely. There may be some exceptions. It's got like a level 1 warning, which is virtually nothing at all. They still tell them that it's safe, and they still use plenty of it. So, and so now, what we're doing now, this is all an exercise of trying to, make more public the real scientific knowledge. And of course, our paper is not only peer reviewed, fully referenced. If people want to contact me, I would be very happy to provide, copies of the paper, the bibliography. You can read all this stuff. It's, it's peer reviewed, published science. So you don't have to take my word for it. You can look it up, and it's there, because that's all I did. I did not do any research. I'm not a clinician. I don't have patients, who are or aren't or want to or don't want to use contraception or any of that kind of stuff. And I have a clinical trial where I have so many women injected and so many not. Or I all of my research is secondary research. So my subjects are not women who are taking or not taking contraceptives. My subjects are published papers. And so what I'm saying is that anybody who has the expertise to sift through it can do what I did. It's all available. And it's, they like to hide things in plain sight. They like to hide things however they can. And so that's the state of play, which is still, unfortunately, a lot of women still being pretty much poisoned by this. So there's no excuse in the Western world, certainly in the US, for having this on the market at all. Not with everything else being on the market, which is just as effective as a contraceptive. It's like if you knew better, the only reason you would keep it on the market is because you're so greedy or so uncaring or so intent upon killing as many people as possible that you want to keep it on the market. The whole idea is to make sure that it's an effective contraceptive for the whole 3 months. Now, it's not an exact science exactly how long that depo, that blob, that basically injection of an oily suspension under the skin will last. And 3 months is not an average, because if that were the average, there would be too many women who would not have the benefit in quotes of contraception for the last several weeks, perhaps, right? If the average were, let's say, 3 months and it went from 2 months to 6 months, you say, well, it wouldn't be that effective. But if you really want to make it very effective, 3 months has to be the minimum that it's effective for. So you got to put more of it in the standard injection, enough to make sure that it's going to last 3 months. So, of course, this is from anyone familiar with the idea of drug design and how these things work, it's a no-brainer that in many cases, if not most, it will last a little longer or a lot longer. There'll be a whole, there's a whole bell curve involved in that. So, of course it does. And I don't have to look at the data to know. I mean, it's just common sense. It's got to last at least 3 months. So you're going to put enough in so that one size fits all and make sure that every woman taking it is not going to be able to conceive for at least 3 months. For some 6, for some, I wouldn't be surprised if there's some outliers that it lasts a year or more. I mean, there's a literature which talks about the thinning of the endometrium, and it's not the best kind of evidence. I mean, let's face it, from a scientific point of view, you want to have, let's take 1,000 women, who get Depo-Provera and 1,000 women who don't, give them either that or a placebo and then follow them and see who can conceive after that and everything like that. All this stuff is not ethical, especially if you believe it's not ethical to give it at all, right? Then, which is of course our position as we started the program with, this is dangerous, a dangerous synthetic drug. It's not really a hormone after all. And so you can't really do the most rigorous scientific experiment. You can't treat people like mice and rats. I mean, you can, but and time to time historically in Nazi Germany and in this country we have. You look at things like the Tuskegee experiment that was done on black men in this country. So it's it can happen anywhere. Wherever the elite thinks they know better than God, you're in trouble. Um, so it's serious stuff, and you can't really tell. So the evidence is really kind of circumstantial, and the problem that I have with it, in terms of the thickness of the lining of endometrium being conducive to the implantation of the new arriving embryo and so forth, and that ability wanes with time. The trouble with the thinning endometrium hypothesis is that every month, when that follicle grows to a mature follicle that's containing the egg, the follicle itself has millions of cells in it by that point, which are making all the hormones. And those are the hormones that cause the changes in the endometrium. So people talk about, for example, breakthrough pregnancies, where someone can be taking the pill or taking Depo and still get pregnant. And all that does is it shows you how powerful the natural hormones locally can be when they're actually generated by the follicle containing the egg. So does it likely decrease fertility? It's hard to say. I mean, I don't. The trouble with finding that out in looking at the evidence is that most women, when they take these things, they don't want to have any more children. So is there a decrease in their fertility? Well, if they wanted to have children and find out about it, well, maybe. I don't really know. I mean, the more definitive unethical mass experiment in that way was done on men, of course, with vasectomy, encouraging men to get vasectomies in the 1970s. Oh, it's perfectly safe, and you only have to do a little incision in the scrotum. It's not major surgery. You can do it in the office. All you got to do is cut and tie off the little sperm ducts. No big deal. If you don't like it and you decide you want to have children later on, we can just undo it. And so it's fine. Well, yeah, they could just undo it. But what they didn't realize, because this was an experiment they unwittingly did, is they said, well, we want to make it so that men can't have children. They can't sire children, right? They can't beget children. But we don't want them to, not to have a fun sex life. So we'll just make sure that the testes are there. We don't want to sterilize the men. Well, what happens is then the testes keep making sperm. But instead of it going through that nice enclosed, sealed duct through the genitourinary tract of the man, the sperm leaks out. And when it leaks out into the capillaries in the scrotum, um, then the immune system can see what those little spermy guys and gals look like chemically. And it's not supposed to be able to do that. It's the testes and the ovaries, for that matter, are called immunologically privileged sites. And when you disrupt that by opening up the sperm making factory to the general circulation and therefore the immune system then attacks it. And slowly, but usually surely, in the months and years after men have a vasectomy, it can no longer be reversed because their sperm making equipment has been destroyed by their own immune system as a side effect of the surgery. So that was another big experiment. Oops, gee, sorry, tens of millions of men worldwide, maybe hundreds of millions of men. Looks like your vasectomy was irreversible. Sorry. But that's a good thing, isn't it? We don't want any more children in the world. That's always the last, or the bedrock of their real intention. But they studiously avoid having it in their argument. This was a very interesting kind of evolution of the science behind it and the technology behind it. Is that they used to, when some decades ago, they first introduced postmenopausal estrogen replacement therapy as a treatment for menopause, and so they would give women estrogen, and then they found, no, that's not really good because it increases the risk of endometrial cancer of the uterus. Oh, we can't do that, right? So this is all still well-intentioned science, properly done science. They say, oh, well, we can't do that. So we will only recommend estrogen for women who have had hysterectomies, which is not an insignificant number, but it's not most women. So what are we going to do with postmenopausal women? We don't want to increase their risk of breast cancer, which is already so prevalent. So what we can do is, if we put a progestin in with the estrogen, we can have an estrogen replacement therapy postmenopausally that will not increase the risk of breast cancer, and they didn't really anticipate that. They found that out when they started prescribing the so-called Prempro regimen, among others, but that's the most popular one, Premarin Provera, same Provera as Depo-Provera. And we'll introduce that, and that way women will not be getting endometrial cancer. But the risk of breast cancer goes up because, and a lot of doctors probably still don't understand this because it was misunderstood some years ago when it was taught in medical school. And you always say, okay, of the two female reproductive steroid hormones, estrogen is the one that promotes cell growth, and progesterone is the one that promotes differentiation and the stoppage of growth. So these are the sort of yin and yang of the menstrual cycle, a proliferative phase in the early part, and then a stabilization and a differentiation into its final function phase. So that's what everybody learned in endocrinology in medical school was, estrogen is the proliferator and progesterone is the differentiator. And that's perfectly true in the uterus, but not in the breast. In the breast, estrogen doesn't do anything without progesterone or synthetic progestin. And when you put the two together, then it promotes growth. Well, if you have all of this after you're supposed to be out of business, after the menopause, and your body is basically, the baby kitchen is closed, right? So you're not supposed to have the kind of stimulation that you get from these hormones periodically. And then what you do is you put in a steady dose of progesterone, which with estrogen, with a little estrogen, which they usually have in these formulations, is going to cause an increase in growth of tissue in the breast, including cancerous and potentially cancerous tissue in the breast. And this would happen actually came out in one of these huge and unethical experiments. That is to say, millions and millions of women were using the Prempro regimen because it was helping them. They were feeling better after the menopause. Women generally like this combination of drugs, so it was popular. But then they found out, because there was a study looking at birth control pills. Remember, we're talking about the same steroids, really, same mix of steroids. So they were looking at, except that in birth control pills, there are higher doses. So there was a study called the WHI, the Women's Health Initiative study. I think it was started in 1999, and it was supposed to go for 5 years. And they recruited women who were taking the Prempro regime versus controls who were not. And they had to stop the study. It was a big multi-center trial, 3,000 or 4,000 women, a very big, expensive nationwide study that was done here. And so they were supposed to look at the data at the end of the 5 years and then look at the data halfway through after 2.5 years. Then in 2002, after they completed their analysis of the data halfway through, they did something that's not unprecedented but very rare. They had to stop the study because the reason for the study was the belief that postmenopausal estrogen replacement therapy, what's called combination therapy, an estrogen and a progestin, would decrease the risk of heart attack and stroke. And when they looked at the preliminary data after half the study time had been done, 2.5 years, the risk of heart attack was significantly increased. That wasn't supposed to happen. So they had to stop the study and say, would be unethical to continue it because it's supposed to help this condition, and instead it makes it worse, or it makes a heart attack more likely. Well, the funny thing is, the data also showed when they analyzed it, and since it got a lot of publicity, it also showed that it increased the risk of breast cancer significantly. They weren't looking for that, and they didn't really play it up very much. They didn't really want women to know that, but they found out about it because of its other side effect on cardiovascular disease. So that's how most of the physicians who were administering this, physicians, usually clinicians, they don't have time to read the literature. They're busy seeing patients, in all fairness to them. But guys like me, I read the literature. That's my job as a basic medical researcher. And they found out that it increased the risk of breast cancer. And therefore, when those doctors who were seeing the patients found out about it, in 1 year, the number of prescriptions for the Prempro regimen fell from 70 million prescriptions a year in the U.S. to 18 million in the U.S. So we're talking about a 70% reduction in the use of this. Now, the follow-up that was very interesting about it is that within a year, within 9 months, they started to see a decrease in the incidence of breast cancer. The first time since records were ever kept on breast cancer incidence in the United States, the incidence actually dropped in around 2000, by 2002 or 3, within a year or so after they finished that study, or didn't finish it, but stopped it. The risk of breast cancer decreased, and not only did it decrease, but who did it decrease among? Among all the women who were like over 50. The 50 to 55-year-olds, the 50 to 60-year-olds, the women who were in the age group that was taking most of the postmenopausal estrogen progestin regimen. So usually a correlation, when you have just a correlation, this correlates with that, that's not really very solid science. But in this case, it was really an intervention, a massive, massive intervention, a massive experiment that produced a result they didn't expect and they didn't like. But the thing that it really let out the dirty little secret that birth control pills and postmenopausal combination contraceptives, combination estrogen replacement therapy, basically the same drugs at different dosages and not given rhythmically postmenopausally, they increase the risk of breast cancer significantly. So at least half the women stopped taking them right away. And it's interesting because whenever we've made the argument that, abortion and contraception cause an increased risk of breast cancer, what do they say? They say, women don't care about that. They don't think about that. That's, women don't care. An increased risk of breast cancer 20 years down the road. That's not going to stop them from taking it. Oh, yeah? Try letting the information actually get out that, hey, this stuff which you like and which is making you feel better and go through the menopause more comfortably, increases maybe by 10 or 15% your risk of getting breast cancer. more than half the women stopped using it right away. So women care about their own health. Men care about their own health. This is all just, more just propaganda arguments that really don't hold any water because their intent is not to communicate the truth. Their intent is to do whatever needs to be done to keep their population control machine, well oiled and rolling along. So, I'm. You might think I'm sort of a monkey wrench thrower, over the last several decades, throwing wrenches into their equipment, and they don't like it. They don't like me because of it. But that's the way it is when you have to get the truth out. It meets resistance. Some people have said, if you're not really doing something that's important, and upsetting the establishment, which is not all that life and health friendly, not all that people friendly. If you don't do something, if they don't really go after you, then you're not really being very effective. That's the kind of thing that can just be calculated. People can come up with numbers. So, for example, if it causes bone loss, then you just add up the number of cases, let's say, of early retirements, or you can always attribute a certain fraction of the morbidity and mortality to certain conditions, which are side effects. So we could say, I know most of the data that I'm most familiar with has to do with abortion and breast cancer. So lots of things cause breast cancer, right? All kinds of risk factors, and so you say, well, that risk factor, no, women have like about a 50% increased risk in the West. It's a many-fold risk, by the way, in the developing world, because all of those other things that cause breast cancer, like not having children, starting to have children when you're much older, not breastfeeding your children, being able to afford a glass of wine with dinner every day, that all of those things are risk factors. So that in the West, there may be a 10% chance of getting breast cancer if you don't have an abortion, let's say, and maybe it goes up to 15, which is a lot, a 50% increase. But in a place like India, we more recently published a study on the subcontinental women who had abortions, and there the risk of breast cancer traditionally is very low because most Indian women, they get married when they're still in their teens, they start having kids right away, they have lots of kids, they breastfeed them all, they don't drink, they don't smoke, they don't do anything else that gives them breast cancer except birth control pills and abortion. So for them, you get like 150% increase. It may go up from let's say 2% to 5%. So overall, you get like a 3% chunk of any population of women. They're three out of instead of 12 out of 100, you may get 15 out of 100 in the West. So that's three more out of every 100. And that doesn't sound like a lot, but what's 100 out of a few billion? That's a lot. It's a lot. It's millions of women. So yeah, millions of people are affected like this. Not only quality of life, but when it comes to something like HIV, it's devastating. You have the situation where you have so many millions of kids really in Africa who are HIV orphans. People are try to adopt them and so on, but it's still a devastating problem when their parents have HIV, they get AIDS, and there's nothing you know nothing in the way of a parent, and so the social costs are, and because they're devastating, and you could say, well, it may only be a few billion dollars, but a few billion dollars in Central Africa is a lot of money. I mean, it's not, I'm not laughing at the situation, just at the foolishness of the kind of reasoning that would say that somehow using this stuff is a good idea among people who, A, supposedly care about other people, the women in particular, and B, know what they're talking about and how these drugs work and what they are. So it's very well, it's kind of inhuman. I don't know the FDA. I don't. I haven't seen much in the way of response. I think in the last administration, the FDA administrator was sort of a placeholder, and now it's more. It's like the FDA is not even the most severe or important censor of information. That used to be, oh, I don't want to say that because then the FDA will tell me that can't say that, or they won't approve any warnings. But now it's the FDA itself which has gotten resistant to telling the truth about these things. So I don't. We haven't. Let's put it this way: in the last couple of years, especially with COVID, but even before that, when the Trump administration was still in in power, although it was near the end of the term, there wasn't anyone at the FDA who would take it on. What you really need is, if you have you need essentially a president of the United States who is willing to appoint somebody to the FDA who really wants to go after this stuff. And so that could happen. If and I say this in all seriousness, if the Republic survives another 3 years, it could happen. I mean, it's a very, very, very scary time we're in. You can, as I say, if you want more information and you want to spread the word about what these things really are and what they do, um, it's good to have a reprint of our paper, which is a systematic review of all the literature on it to show what's wrong with DMPA, Depo Provera, in particular. But we just have to keep hammering away at it, and I think we understand that right now there are a lot of political headwinds. But the more people who know about it, the more doctors who know about it. I mean, imagine if you're just a woman who wants to be informed and you want to inform your doctor. You can hand him or her a reprint of a paper and say, "Oh, by the way, this is not too good for my daughter, is it?" What about that? If enough people ask, it's like anything else. You have to make some noise about it, and it's difficult to do. But I think maybe when the political winds shift, we can really make some progress on it. That's so. God will give us what we need to do what He needs us to do. Just have faith that way and enjoy our Thanksgiving dinner.